Here we have a case of cyanotic congenital heart disease. The key clues are long-standing central cyanosis, exertional dyspnea squatting after exertion, and cyanotic spells. This combination should immediately make us think of a reduced pulmonary blood flow lesion, especially Tetralogy of Fallot. On inspection, notice the central cyanosis and digital clubbing. Clubbing tells us this is chronic hypoxemia, not an acute event. The lateral thoracotomy scar is also a very important clue because it suggests previous palliative surgery, most classically a Blalock-Tausig shunt. At this point, always compare both radial pulses and blood pressure in both arms. So what does the scar suggest? It points toward a previous systemic to pulmonary shunt, done to increase pulmonary blood flow before definitive repair. On the same side, the radial pulse may be diminished and blood pressure may be lower. A continuous subclavicular murmur may also be heard. Even the side of the scar can hint at the side of the shunt. On palpation, a parasternal heave suggests right ventricular pressure overload. A systolic thrill at the left upper sternal. Border supports turbulent flow across an obstructed right ventricular outflow tract. The apex is usually not displaced and the JVP is usually not raised. On auscultation, the classic finding is a harsh ejection systolic murmur, best heard at the left upper sternal border. This murmur is due to right ventricular outflow tract, obstruction or pulmonary stenosis, not the VSD itself. The second heart sound may be single, or the pulmonary component may be soft. One important pearl, if the obstruction becomes very severe, the murmur may actually become softer because forward flow falls. The investigations support what the bedside has already suggested. ECG typically shows right axis deviation and right ventricular hypertrophy, sometimes with right atrial enlargement. Chest X-ray classically shows a boot-shaped heart, reduced pulmonary vascularity, and sometimes a right-sided aortic arch. Echocardiography then confirms the anatomy and severity. Putting it all together, cyanosis, clubbing, squatting, RV heave, a left upper sternal border ejection systolic murmur, a previous shunt scar, and a boot-shaped heart with pulmonary oligemia strongly point toward Tetralogy of Fallot. The overall pattern is reduced pulmonary blood flow, not pulmonary plethora. Tetralogy of Fallot is remembered by PROV, pulmonary stenosis or RVOT obstruction, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. The severity of cyanosis depends mainly on the degree of RVOT obstruction. TET spells may be triggered by exercise, fever, stress, dehydration, or acidosis. Acute management includes knee-chest positioning, oxygen, morphine, IV fluids, and a beta blocker, with correction of acidosis if needed. In repaired adult TOF, always watch for pulmonary regurgitation, RV dilatation, arrhythmias, and a wide QRS.